Welcome to the King's podcast, The Wellness Diet with Lucky. I'm your host, Esther Lucky. Type 2 diabetes is one of the most common chronic conditions around. But we are always told that one of the ways you can manage it is through weight loss, or if I might say, weight management in a healthy way. Today, we are joined by Dr. Emran Khan, consultant and director of the King's College London Diabetes, Endocrine and Obesity Institute in Dubai Hills. He'll be here to introduce to us and tell us more about a new drug that can allow you to lose more than 22% of your body weight if you have diabetes type 2. Welcome, Dr. Emran.
It's a pleasure. I hope the audience find this discussion helpful.
It should be very, very interesting because it's all about weight loss. And we all know weight loss is like when you're trying to lose weight, it's like you're fighting for your life.
Indeed.
Yes.
It's a challenge for most of us.
Yeah, it is. So tell us about this drug, the weight loss drug. I believe it's called Mounjaro.
This is a drug which is a novel drug which is new on the market. It's been out only about a month at the moment. So it's a very new drug which was recently approved by the FDA. That's the American licensing authority. And it's now licensed to be used for type 2 diabetes, particularly those with type 2 diabetes and obesity. It's a very effective drug. It's come in a long line of drugs which were called glucagon-like peptide. But this has a different molecule and it works in two different ways, which includes working on the GLP-1 but also on the GIP, which is a different hormone. Both of them are produced in the intestines, and the GIP helps boost the efficacy of this, and it's responsible for a reduction in weight. And if I may go on to say that how it works is that it reduces your appetite, and the message to the brain goes to say that you're full and you don't need to eat anymore, which many of us lack, and we just keep eating and don't realize that we're full. So it helps with that. It also keeps the food in the stomach longer, so it doesn't go through. So it stays there. So again, that stretches the stomach and it gets the signal of I'm full. Then it works in other ways also by making the insulin more sensitive, improves the efficacy of your own insulin. And all this combined, as the weight goes down, the body becomes more efficient to deal with your diabetes. So it's directly responsible for helping the blood sugars, but also indirectly by reducing the weight. And as the weight goes down, so weight is not just for diabetes itself, and we know that about 80% of our type 2 diabetics are overweight, unfortunately. And but it has other consequences. As we all know from obesity, your risk of cancer increases significantly, your incidence of heart attacks or strokes increases, blood pressure increases, your incidence of gout or arthritis increases, you need more hip surgeries, your knee surgeries, and high cholesterol. So it has an effect on most of the organs on the body, and the benefits are not just for diabetes but for general health also. So it's a very, very effective drug, which is just another tool in our managing diabetes. So I wouldn't say this is the only thing, but it's a very welcome drug and a breakthrough because it's significantly different from the other tools that we have.
Yeah, thank you, Doctor. So let me take you back a little bit. You just mentioned that 80% of the people with type 2 diabetes are overweight. So what's the connection between diabetes and being overweight? Does diabetes cause people to be overweight, or does the obesity lead to type 2 diabetes?
Yeah, so this is somewhat a chicken and egg situation. They do contribute. I would go as far as saying basically obesity leads to diabetes in those people who have a genetic predisposition. So our obesity in most people is about 75% it is in our genes. And then 25% the environment works on us. So if there is a family history of diabetes, then if you put the wrong environment to that body and they put on weight, then they develop diabetes and it becomes obvious. Whereas if you have that gene but your weight is down, then you don't develop diabetes. So diabetes brings up or comes up when the obesity comes. So I wouldn't say that diabetes causes obesity. In some ways, yes, diabetes causes insulin resistance, and that takes you into a vicious cycle and contributes, but the major portion is the obesity. And we also know from very good and clever studies, especially done in United Kingdom, in Newcastle, where they had a diabetes remission program, which we've also had here. It's a very intense program where you give a patient 800 calories of meals, which are meal replacements under supervision.
These are the liquid meals.
Liquid meals. And that then reverts the diabetes into what we call diabetes remission. And why we say remission, because it can come back if you put the weight on. But that's quite a challenge really for most people. But it just proves the point that yes, weight reduction can resolve the diabetes problem in most patients.
Okay, so if I heard you right, you mentioned that anybody who's morbidly obese can possibly have the injection.
The medication that we have, we're talking of Mounjaro. This is now licensed by the FDA only for type 2 diabetes. However, having said that, the other drugs which were similar to this, such as people may know it as Ozempic or semaglutide or liraglutide 6, and these have been licensed for obesity in different forms, and they all developed for diabetes, but then they got a license for obesity. Now, to get a license, you have to prove and you have to go certain trials to make it licensed. Now, the FDA approves licenses for drugs which do at least 5% weight loss, so they feel it's effective. This medicine can take you up to about 20% or even more. There are studies ongoing, and we should get them in 1 year's time, not too long. And I'm certain that they will prove to get a license. At the moment, we, in expert hands, an endocrinologist who has experience may use it with the consent of the patient to patients who are not diabetic, but that would be off-license management. And I wouldn't encourage people to use it unless they know what they're doing.
All right. Thank you, doctor. So just asking for myself, and I'm sure thousands others out there. Let's say if I go lazy for 1 year and put on about 10 kgs or 20 kgs, and I come to you and I tell you, doctor, I need to get rid of these 10 kgs. Would you just recommend it or just prescribe it? What's the process? And would you recommend somebody in such a position to take such a step?
Yes. The right way to do it is obviously to understand why they happened, understand what took them. It may be due to many people put on weight in COVID. They stopped going to the gym. They were having more takeaways. And we've seen this recently. A lot of people have put on about, in fact, what you say, 10 kilograms in COVID time due to restrictions. The ways particularly patients are vulnerable here because of the wonderful opportunities and lifestyle we have here. Again, as being an obesity specialist, and this being my specialty for about 30 years now, I would first go through a discussion with them, lifestyle changes, see how we can manage this, manage their calories, the quality of food. And then if we're not successful, which we hope we will be, because many patients would be successful with natural lifestyle changes and dietary restrictions and reduction of calories. If they're not successful and there are other comorbidities which make us think that this patient is at a high risk, then yes, it could be considered for such patients.
Okay, so we should not take it as a shortcut to weight loss.
I wouldn't think so, because end of the day, you are what you eat.
Of course.
And what this drug does is actually, in many ways, apart from different mechanism, is reduce your calorie intake. And that's what bariatric surgery does, because it does act in different ways. But the main thing is that you can't eat enough. So when you can't eat, so it's not rocket science. You eat less, you lose weight. The interesting thing is that this drug is very comparable to bariatric surgery, which people have benefited a lot over the years and still benefit, and it's a recommended treatment for patients with comorbidities, and is effective. But this has now come as another tool in our bag to help patients who are either not ready to have bariatric surgery, because it gives very similar results of bariatric surgery by reducing the weight by such a large amount with health benefits.
You mentioned that Mounjaro promises to help an individual lose up to 22.5% of their weight. Let's say somebody is 120 kilos. If they do the injection, how much are they going to lose?
Right. It all depends on how well the patient works with it. So it's not just give a pen and saying off you go and you lose 20 kilos and everything will happen magically. So we as experts will have to work with them and guide them through this process. And the weight reduction is dose dependent. So we start with 2.5 milligrams, and we go to 5 milligrams, and we go to 7.5, 10. And the maximum weight reduction which we've seen is at 15 milligrams. Now, 22% is one aspect. Not everyone reaches 22% of weight reduction. Most people will reach 15%. But if you work with it, then yes, you can get to those targets.
But then the weight loss is in addition to exercise and diet, or it's just, the medication will just take the weight off on its own?
The role of exercise is obviously somewhat, I wouldn't say debatable. It's an important part to help with your well-being, increasing your metabolism, and helping you maintain weight. So for weight maintenance, exercise is essential, and for your health benefits, essential. But if somebody thinks that they will lose their weight by keeping their diet constant and working out in the gym for an hour, many of them will be disappointed because the amount of calories you burn with the gym are negligible to what we can have in one meal. So it will take you 3-4 hours of a gym work to lose one meal. So yes, exercise works, but you really need to live in a gym to not change your diet and lose the weight. So I don't want to take the focus away from exercise, but I want to make this concept. Also, some people, it's a psychological thing. People go to the gym and they will do an hour's exercise, and then they feel so good about it. One, they get hungry because they've done exercise. So they will have a smoothie, which would be 200 calories or so. And whatever they've burnt, half of them they take. And then they say, okay, this week I've been good. I've been to the gym. So I'm allowed to have some extra treats. And they actually work against their exercise. So it's not the fault of the exercise, or the exercise doesn't work, but they reward themselves for the exercise, and they undo whatever benefit they've gone to achieve.
All right. Thank you, doctor. A change of gear now, back to Mounjaro.
Yes.
So what makes it more special than the other weight loss medications? If you don't mind, just take us into a deep dive history of weight loss medications here.
I'm in a good position to take a deep dive because I've been around long enough to go through many of these medications. In fact, interestingly, the drugs, the GLP-1 drugs, which we have available, including Mounjaro, I was a registrar in Hammersmith in London, where I was doing a diploma in diabetes, and we were working on GLP-1. At that time, it was not a drug that was available. We were giving it in a drip, and we were seeing the effects of this. So this is, we're talking of, I don't want to show my age, but we're talking of 1993. And you can see the journey. This is like we're 30 years on, and now it's into a drug. So that's how long it takes and how much effort it takes to get a drug developed, become efficient, and come up on the market. We had initial drugs which worked mostly in the brain, and they made you lose appetite. But we found with time that they caused psychological problems, and there was an increased incidence of suicides and so forth. So they were like amphetamine derivatives. So they were taken off the market. Then we have some still available which are working on the opioid receptors. Again, they're effective and still available, but have got certain effects on the psychology of people. So they may not be very well tolerated. Again, it's a tool which we use. And then we had another one which was helpful and still available, which is called Xenacol, or another name was called Orlistat, that lets your fat not get absorbed. So whenever you eat fat, you don't absorb it, so you lose the calories, and it helps to lose weight. But if you take a fatty meal, you have to rush to the toilet. So it punishes you whenever you have a fatty meal. So patients sometimes learn from this mistake, or sometimes stop taking the drug.
So that they can enjoy their burgers.
Yes, and they want to then carry on with what they enjoy. And then comes the GLP-1s, which we've used very successfully and still used, which help you with weight loss. But this, obviously, the initial GLP-1s did about a 7% weight reduction. Then the Ozempic or semaglutide did about a 15%, and this one's going to about 22%. So you can see it gets us better results. So hence more efficacious.
As we know, all drugs have some sort of side effects. I mean, this drug sounds too good to be true. What are the possible side effects of this?
Yes, true. Everything we do has side effects. I sometimes tell my patient that when you come to see me, God forbid, you can have your car may break down, you can get stuck in a lift. It's a side effect, but it's not a side effect, but these are risks in life, and you look at them and you weigh them against what benefits you get. So when we're using any drug, whether it's blood pressure medication, cholesterol medication, diabetes, you see what the benefits are and what the drawbacks are. Now we know the side effects or the effects of obesity are so high and so immense on the future of that person to be able to mobile and be able to play with their grandchildren and not have knee replacement, heart attacks, diabetes, and all the things that are associated with obesity, that we then have to see, okay, this drug gives side effects. Are they worth taking? That's when we say, yes, it is, or it isn't. And for those people who fulfill the criteria of high risk, then this drug is safe and effective, and there have been studies to show it's safe. The main side effect that is nausea, and you feel like throwing up, and that tends to happen in the first 2 weeks as your dose increases. But I say that to my patients, but many of them tell me, you did tell us and you scared us, and I was expecting to throw up, but nothing happened, which is really good to hear. But about two to three people will have that side effect, but it passes by, so it's not unbearable. The other smaller side effects, some people will have bowel changes, either diarrhea or constipation. Again, these are in the initial days. These are the main side effects. We know that we have had some incidences with the previous drugs with pancreatitis or inflammation of the pancreas. So we don't use it with anybody with history of pancreatitis. So it's contraindicated for them. And there have been some cases of thyroid issues with rats in research, but we don't see it very much, or in fact I've never seen one, and I've used them for many number of years. So I would say the side effects are manageable, bearable, and certainly the benefits outweigh the side effects.
The side effects. All right. Thank you, doctor. So lastly, before we let you go, because we understand you have a very busy clinic, how long is one supposed to take this medication for?
It depends on, again, every person is individually assessed. I would think a minimum plan would be 3 to 6 months, and then assess the patient and go along with them. But the studies have gone to more than a year, so we're talking of a year. It all depends on what our starting point is, what our targets is. So I think it's a individually based target where we get, and also it depends on how the patient's working with us, because the drug itself is not magic as we would hope it is. If the patient doesn't work with it and reduction of calories and change their diet, it's not going to work. I used to say that lettuce is the highest calorie food.
Really?
Yes. Why?
I thought it's just water.
Yes, but that's why I say that with experience. Why? Because when I ask my overweight patients what do you eat, they say I only eat lettuce. So it must be a high calorie diet. But it's not the case. Sometimes patients realize what they're doing, and sometimes their lack of knowledge of knowing how much calories are put into a certain food item, they are not aware of it. I use the example of an avocado usually because it's
healthy fat.
It's very healthy fat, but in calories, it's as much as having 2 scoops of ice cream. Healthy is one thing, and calories and weight reduction is another thing. So there are some misconceptions which need to be managed and understood for weight reduction. So healthy is important, but healthy doesn't mean that you can have any amount. Like olive oil is healthy, we all know that, and butter, some people would say, is not as healthy, but the calories in butter and olive oil are exactly the same. So people think, okay, if I can have olive oil, that's kosher and that's fine, I can do as much as I want. No, that's not the case. Similarly, brown bread and white bread have very similar calories. So they think, oh, if I'm having brown bread, it's fine. So it's these sort of discussions and giving patients knowledge and understanding is essential. So if they work with us, we achieve our targets in 3 months. Similarly, we see with bariatric surgery, if the patient works with the dietitian and they get good results.
Wow, doctor, that is so insightful. Olive oil, avocado, lettuce. I mean, those are the healthy foods you go for. And now here you are telling us they're not so good after all.
I'm not saying they're not good. They're very good, they're healthy, but everything in moderation.
Everything in moderation.
And looking at how many calories you require in a day and balancing it out. And we have to have a negative input so that we can burn what we have stored. So over the years, we store food and then we need to use it. Now, whatever our stored food is our fat, which we need to utilize. So when we're losing weight, we need to use the store food. I usually use an example of a refrigerator and a freezer. So you go, you do shopping, you put it in your refrigerator and you use it that day. Now, if you go to the supermarket and they have a sale and says buy 2 get 2 free, so bring an armload of food and you go to your refrigerator, it's full. So what do you do with it? Put it in your freezer.
Yeah.
To use another time. Now, similarly, let's say we need 1500 calories and I go to a party or have a takeaway and I have 2000 calories. So what do I do with those 500? I put it in my freezer or on my fat. Now, the idea is to use that when I don't have enough 1500, so I can use those reserves. But whereas what we do is we keep filling our freezer and buying more and more to put in our refrigerator. So we never get a chance to use the freezer stuff or the fat. So with this Mounjaro or with any weight reduction plan or bariatric surgery, we are restricting our calories. The body wants 1500, we give it 1000. So that 500 then comes from the freezer. And that freezer, when we take out the calories, we burn fat and we lose weight. So it's not too technical, really.
Yeah. Understood. So, Mounjaro, you work with the patient until they reach their weight goal. What happens after that? Does the weight come back the moment you stop treatment, or how does that go? The patient has to keep seeing you for the next 10 years?
Hopefully not. I think a couple of things will happen. One, the patient's obviously motivated and has put in a lot of effort and taken the medication, and they've achieved that. That gives them a sense of happiness, pride, and they see the benefits. They will actually feel comfortable when they walk, when they go to the gym, in their daily activities. Tying shoelaces is easier for them. So they will not want to go back. Now, then they don't have to be that restricted in their calories, because now we're talking of weight maintenance and not weight loss. So they're allowed more calories and more food, but whenever they exceed that, they will start putting in. So now hopefully they will understand that if I do that, I'll have to go back to the whole thing, and they put in so much effort. So they would have learned from it. Also, I would expect that the stomach size physically, which is a stretchable organ, will shrink, and they will feel fuller when they eat. also it changes our eating habits. So people have certain habits that at 10 o'clock I'll have breakfast, 10 o'clock I'll have a coffee and a biscuit, and at 4 o'clock I'll have a pastry or something,
Yes.
and then before in the evening after dinner I have some nuts or some salad or not salad. After dinner I may have some ice cream or
some chips.
When that habit changes, because you've stopped shopping, because you don't feel hungry, you change your habits, and hence hopefully those habits don't come back, and your lifestyle changes, and hence you will be able to maintain that weight.
Thank you, doctor. Thank you for joining us today.
Thank you very much.
You have it, ladies and gentlemen. Mounjaro promises to help you lose up to 22.5 of your body weight. Dr. Emran Khan is the consultant and director of the King's Diabetes, Endocrine and Obesity Institute. To sign off, he's going to tell us a little bit about the institute and how it can help you as a person and as a patient.
King's College Institute of Endocrine, Diabetes and Obesity is a new institution which we've opened. We have experts with us. We have 5 endocrinologists who are all very experienced. And I hasten to add that being King's College, all of them are British trained. They're all experienced consultants, having worked in UK for more than 5 years as consultants. So they're all got a wealth of experience to help our patients here. They are all endocrinologists and specialists in obesity. We also have a team which we are developing, and now we're going to go have a separate center where we will be having a dietitian, a podiatrist, and all the allied specialty, including vascular surgery, bariatric surgery, hepatologist, all the aspects of diabetes which affect our patients all under one roof, including ophthalmologist, so we can help our patients with diabetes under one roof, so we can give them the expert state-of-the-art knowledge and experience for them to deal with their own condition. It's a lifelong condition, and we're well suited to provide them that all under one roof. And obesity being one of our expertise, we will be providing that service there also. So if somebody has an issue, then there's no better place than coming to King's with the highest British standards we have here.
All right, doctor. Thank you so much.